Hey, I wanted to talk today about pregnancy-related stuff and how it relates to chemical dependency treatment. So it turns out that I deliver a lot of babies. I've delivered over 1,000 babies here on Kauai over the last 10 years. And I kind of pride myself on being the one doctor on this island who is both comfortable uh, with patients who are pregnant and also comfortable with patients who are struggling with chemical dependency problems. And a lot of women who are pregnant who also are uh, trying to overcome or trying to control a chemical dependency problem find that sometimes the doctor that they've been seeing to help them with their chemical dependency, once they're pregnant, they're very uncomfortable. And likewise, if they bring the problem up with their obstetrician or their doctor helping them with their pregnancy, that also, that person's uncomfortable managing that problem. So a lot of the women on this island who are struggling with chemical dependency problems and who want to treat them end up under my care. So uh, one of the more common misconceptions about treating chemical dependency problems in a pregnant woman is that the woman who's pregnant fears that if she divulges the fact that she's struggling with a chemical dependency problem, or at least reaches out for treatment, that that's a strike against her. And so a lot of times when women are thinking about this, they're concerned that some agency like Child Protective Services or whatever will take the baby away if they say that they have a chemical dependency problem. And in my experience over many years, it's exactly the opposite. It's the women who don't seek treatment for chemical dependency problems who end up having problems with maintaining custody of the kid, because very often the problem is known or suspected because of just their behavior or positive urine tests or what have you. And what Child Protective Services wants to know is that a woman has sought treatment and she's engaged in treatment and she's trying to control the problem. That's all they want for the mother and the child, not anything more than just recognition and action on that subject, and to make sure that the baby is in a safe environment. And so most of my patients, luckily enough, are engaged in treatment, engaged in managing their chemical dependency problems, so have no problem with going home with the baby, etc. So I want to go specifically into what we're trying to accomplish. So a lot of the times, you know, the main objective is to reduce exposure to the chemical. So if it's alcohol or meth or benzodiazepines or other sedatives, etc., the goal is to remove the exposure of the developing fetus to the chemical. And so we focus mostly on abstinence and trying to control withdrawal symptoms and those sorts of things, so that the mother is more able to engage in recovery and, of course, supporting her recovery efforts. But it's a little different with opioids, heroin and oxys and those sorts of things, because they're so widely available, and it's such a problem with maintaining sobriety. And we've got good medicines that are known to be safe for maintaining somebody on opioids. Generally, what we're trying to do nowadays is have somebody switch over to either buprenorphine or methadone, if there's a methadone program where the person lives, so that they're not going through withdrawal, which is stressful on the developing fetus's brain, and also not potentially relapsing and then maybe overdosing or maybe injecting and getting bacteria or other infections into their system that could affect the pregnancy. So what we want is stability. And so I've been prescribing buprenorphine to pregnant women for like 12 years or something like that. And generally it goes very well. And so the buprenorphine, of course, blocks the opioids from working if they were to take them. Of course, stimulates the opioid receptors so they're not in withdrawal, and just creates a very stable kind of prenatal course. And then when the baby's born, there is some concern about the baby going through withdrawal. But generally speaking, since buprenorphine is so long acting, it kind of gradually wears off. And if you give the baby enough support and feeding and that kind of stuff, babies generally do very well. And I have just not had a lot of problems with babies having problematic withdrawal that require like medications and those sorts of things, even on women who are taking pretty sizable doses of buprenorphine. The truth is that there does not seem to be a absolutely predictable relationship between the dose of buprenorphine and the baby's withdrawal symptoms, but that being said, generally the more buprenorphine you're taking, the more risk there is for the infant, the newborn, to be in withdrawal. So that's kind of what we are trying to accomplish for women who are struggling with opioid dependence. But for all women, whether it's alcohol or opioids or other drugs of choice that we're trying to manage, there's really good programs here on Kauai to help support pregnant women or new moms who are in recovery. The Ialoho program that's sponsored with Child and Family Services, which is a non-for-profit service agency here, is very good, and there's just a lot of resources that are available. So for the non-kind of doctor-related treatment, prescriptions, and those sorts of things, there's a lot of resources, groups, and individual counselors, and those sorts of things that can help assist women who are trying to kind of get things straight for when the new baby comes. So, there's certainly some long-term neurologic concerns about babies who are exposed to methamphetamines and to cannabis, especially it seems like nationwide as cannabis becomes more widely available through medical marijuana or just through legalization for recreational use across the United States, the use of cannabis in pregnant women has gradually increased. I think it's either doubled or tripled over the last 10 years. And we know for certain that cannabis exposure in adolescence can cause a substantial increase in future psychiatric problems. So cannabis is not a benign substance, and the components of it, THC, CBD, etc., certainly are concerning for their potential to cause long-term neurologic and psychiatric problems in babies later. And the same, is true for other chemicals, including alcohol. Alcohol definitely is toxic to fetal development, and alcohol use during pregnancy can result in fetal alcohol syndrome, which is a combination of physical features and neurodevelopmental problems that occur in babies who are exposed to alcohol in pregnancy. Sometimes I'm asked, like, is there a safe amount of alcohol used during pregnancy? And we really don't know that. There's a substantial genetic kind of range of susceptibility to alcohol. And so maybe there's a fetus who's very, very susceptible to small doses, and another fetus who may be more resistant and more resilient and less likely to develop, problems and toxicity related to alcohol intake. But in my practice, the answer is absolutely no. There is not a known safe limit of alcohol intake for every fetus, and it's just not something that we recommend. But like I was discussing before, sometimes there are medicines that we give that we feel are a benefit to the fetus and the mom during pregnancy that allow us to to maintain a level of control and stability during the pregnancy. So that's just a few thoughts I had on pregnant women in chemically dependent type situation, and so hopefully that's helpful to you guys. Thanks so much.